So let's start with what are we doing here with this particular title? I was as perplexed by this one as Cliff was by the last one. And there's some good news in that title, in that when I tried to have this discussion in 2008, when we were setting up the United Healthcare oncology team, I got the following answer: I know quality when I see it, and cancer is too complex to measure, so just trust me, we'll tell you when there's quality. And the good news is I think we're past that now. And then I think the second thing that's interesting about this title for me is the word outcomes. Because everything that has been measured in oncology up until the last couple of years was not outcomes, it was process measures. And this is a really welcome transition for me. So let's go ahead and take a look at all of my biases about quality measurement, and then we can start a debate. I split the world into two sections today. There are those quality measures that I call formal. And as you can see, they're used for accreditation or for payment purposes. I put initially, when I was putting these slides together, that they were public, but you know, the more I think about it, the more I think they're actually sequestered most of the time. And you have to have measures that, because they're for payment, people want to do well, so guess what? We pick measures for these kinds of purposes where compliance is already in the 90% range, because people want their accreditation, they want to get paid, and that means they're acting pretty rationally, so they pick a measure that they can get through very quickly. Those kinds of measures also, everybody gets picky. If there's money or accreditation involved, they want them to be 110% accurate. They want there to be multiple exception criteria so that the outliers are all kicked out. And it takes years to develop them because they have to go through multiple iterations of public hearings to get a measure. So in other words, I think they're worthless. And what I'd like to do is skip these kinds of things and talk instead about measures that are used for quality improvement. Did any of you have to suffer through quantitative chemistry in college? A couple of people here, good, good. This is the difference between quantitative chemistry and organic chemistry. In quantitative, you had to be very precise and measure that last molecule. In organic, you throw a little of this in, you throw a little of that in. It's like cooking in Italy. And that's what quality improvement measures are about. They're fast, they're quick. They are, you can use a lot of different databases and methods, and the results can be really embarrassing. But the purpose of those results is to get better. It's to find gaps and then see that if we could improve them. And accuracy for a quality improvement measure has to use what I call the hand grenade and horseshoe criteria. Close is good enough. Okay? And then finally, they can be inclusive because you're trying to move quickly here. You're trying to find out what you can, how you can measure changes that you make in your processes. And being inclusive gets you numbers faster. And they have very, very short development cycles. So what I'm going to do here is take you through a little bit of how I might look at some specific examples. And one question we need to address right away is, what should we be measuring? And one of those is outcomes. I'm going to spend a little more time on that. But notice that Amy Berman's first thing she looked up was, what was the outcome of my disease? And then I'm going to use the term patient-relevant outcomes. If you've read Michael Porter's piece in the Harvard Business Review about a month ago, anybody familiar with this? Not enough. I would suggest that you really go back and read Michael Porter's piece about measuring value in healthcare from the Harvard Business Review. It's about 1 or 2 issues back. He brings up the term patient-relevant outcomes, and I think it is a critical point. These are things that may not be as important to us as providers of care, but are critical to the people who are on the other end. And you heard Amy talk about those today. What's going to happen with me with my therapy? How many times might I be hospitalized, or could I be disabled by this therapy? How soon can I return to work? What did other patients think of this therapy or this particular institution? Now, those are typically things that we don't think about as physicians. We accept there's going to be some morbidities. We don't particularly measure it, may not even talk about it with patients. It is critical to them. And when you look at the surveys of what they are interested in, those are the kinds of things you will hear about way above even what the cost of the therapy is. But they do want to know what the cost of the therapy is. And I'm going to argue all day today that financial measurements are an important piece of quality. Because if you can't afford access, it doesn't matter how good it is. All right? So I'm going to use examples today that come from a database that we put together at our little shop. And we did it for about the cost of one course of oral specialty drugs. What we asked physicians to do was to fill out a single piece of paper. And that paper said, for breast, colon, lung, prostate cancer patients, would you give us their histology, their stage, some specific gene tests that were relevant, and their current status? Have they relapsed? Are they in adjuvant therapy? Are they in remission? And we took that data and combined it with all of the claims data that we have on those members and created a longitudinal record. So now we have the ability to clump together patients who should have similar characteristics. And to the physician community's credit, we got 70% of our fax forms back on a voluntary basis. I think it says a lot of good things about oncologists. And we now have 65,000 patients in that database with that information loaded. So a lot of what you'll see today comes out of that database. So here's example number one to talk about. And I think the points that I want to make on this is a simple graph of early stage breast cancer, ER/PR positive, HER2 underexpressed. And one of the things you can do with any kind of data like this is start generating hypotheses. All of the drug costs, and this is our national standard for this, these are 5 groups that participated with us with the episodes program. And we measure how much drugs cost for each of those regimens, or for each of those categories in the blue line, and they all have the same fee schedule. This is just ASP. Okay? You'll notice that these 5 groups are all using TC chemotherapy for that category of patient, and yet there is a 2-fold difference in their costs. And so what we discovered as we got underneath that is that they weren't using TC, that a lot of these patients were getting adriamycin-containing regimens, and that was the reason for this difference. What it told us is we had the wrong measure. The discussion that we had about this variance here was that people thought oncotype score high-risk patients deserved adriamycin therapy, and low-risk patients in this category, who had a low-risk oncotype score, could be treated with TC. We didn't set it up correctly, but we were able to correct that in about 1 week. And now we have a new measure that splits into high and low risk, so we can start having the next hypothesis discussion. Fast, quick, changeable, and on the fly. And that's the point I want to make about a QI type of measure. Here is another one. We're looking at hospitalization rates that are relevant to early stage breast cancer and adjuvant. And you'll notice this is the striking number for us. And this is where I want to talk about patient-relevant outcomes. We have 78 hospital days for every 100 episodes of adjuvant breast cancer therapy. And I've talked to Craig Earle in the Ontario province here recently, and they are finding exactly the same results. Now, how many of you, when you sit down and talk to a woman about to get adjuvant cancer or breast cancer therapy, tell her that she's got about a 2/3 chance of being hospitalized for toxicity during that episode? Anybody do that? Amy Bourbon would like to know that. And think about that patient who's considering an adjuvant chemotherapy regimen. You go on Adjuvant Online, and she's about to get a 3% better survival if she goes through it. And now you tell her, well, yes, but you got a pretty good chance of going in the hospital, and this is our actual mortality data for adjuvant therapy, and 7 patients in the United Healthcare System died getting adjuvant breast cancer therapy. Now, I want to put this in context. This is out of 3,000. It is a very small percentage, but if you're chasing a 3% survival improvement and you've got a good chance of going to the hospital and even a tiny chance of dying, would the patient think about that differently? And I would answer yes. They should at least know that data as they make their decision, and then Amy Berman can decide what she wants to do. Okay? Those are patient-relevant types of measures that I think would help inform things. The other is outcome. And this is, again, some data from our episodes program. We were, in fact, changing the way physicians got paid, and they would potentially be using fewer resources. So, of course, everyone wanted to know, would patients be harmed by that approach? including the physicians in the episode program. They're very interested in that. And these are the survival curves calculated off that same database I told you about, and the good news is they're superimposable. Now, this data has been available, survival curves like this, for every cancer in the country. There are 6,000 hospitals with tumor registries that have this data from their institutions. They need it to get accredited by the American College of Surgeons. They do not release this data. And wouldn't Amy Berman be interested to know if her hospital is on this side of the curve or that side of the curve? She can't find that out. Okay? The notion has been is that patients aren't smart enough to use that data correctly. They won't risk adjust, and I think that's baloney. I think that's critical information for people to know. And the point I want to make to all those hospitals that are still keeping that data secret is that I can get it anyway, and we are, as is every other data provider in the entire country. So it's time for us to get very explicit. Amy knew exactly what her prognosis was, and she knew how it changed when she had metastatic disease, and she deserves to know how her various institutions are doing. This is yet another example of the same kind of data. Our episodes groups wanted to track the average time to progression for their first chemotherapy regimen after a patient relapsed. Okay? And so we're starting to track that. We are able to do that through claims data. And as you can see here, the group in A is using a regimen that seems to get rather strikingly different results from the rest of their cohorts in metastatic breast cancer. And so there's been a discussion about what that might look like. Now, the problem here, look at those numbers. They are very, very small. But over time, we will be accumulating more and more data. This is just 5 groups. We're dealing with 6,000 oncologists nationally. So as we begin to put their data into the same system, suddenly I think it's time for us to reconsider a little bit about what we might be doing. And I'm going to switch ahead to a concept that we might be measuring the wrong thing. If we can now look at outcomes, and if I can, as a payer, gather data on hundreds, if not thousands, of patients with a specific clinical diagnosis, treated with several different regimens, we should be comparing the chemotherapy regimens, not the doctors. And if we find a chemotherapy regimen that has much higher toxicity for the same outcome, much higher cost for the same outcome, that belongs in a Mark Fendrick column that says you have to pay more to get that drug, or it shouldn't be covered at all. Okay? And if we could find regimens that maybe in fact be getting much more superior results, I don't know if that's true or not, but those particular regimens should now be given preference in our coverage documents. So the data is rapidly becoming available for us to start profiling chemotherapy regimens. And I'm wondering if, again, instead of measuring doctors and providers, if we shouldn't instead be measuring the regimens and using that information to decide what we do and don't cover in real-world patients. Okay. So now I want to talk a little bit about QI, or quality improvement, because this is the kind of stuff that can help a lot. That particular group, that little green dot, I don't know if you noticed on the other adjuvant regimen, they're out here on every graph that we do. They had a very high hospitalization rate, and they didn't know it. When they went back and looked at their process, they found out that when a patient was hospitalized for toxicity, as the patient was discharged, they were told to call the clinic, get a return appointment, and that average return appointment was about 30 to 40 days out. These people got sick again, landed back in the hospital. They've now changed their process to an appointment is made within 48 hours before the patient leaves the hospital, and they are rapidly pushing their statistics right over here with the rest of the people. And that's, again, what quality improvement measures are about. This was an embarrassing number for them. On the other hand, if they didn't know it, how could they do anything about it? And they did, which is the whole reason for doing, in my mind, quality improvement types of measures. This is another example of variation that I'd like to spend some time on. All this graph does, it's very complicated, is it looks at the number of procedures and the cost of those procedures for a 4-month period for patients with metastatic cancer, breast, colon, and lung. And the key point about that is those bars are about, they can be different by a factor of 4. among people who are all treating the same kind of cancer. Okay? And that gets us to my favorite hero, Brent James. Brent, when we tried to wrestle with this problem as we went to the medical groups and said, how could we get some kind of reduction of that standardization? What we got were 18 different articles. We should do 3-month intervals. We should do 1-month intervals. The trials say we should do 2-month intervals. And every person had an article and every person was right. And we have not solved the problem. So what Brent would say, who runs the Intermountain Healthcare Quality Group, it doesn't matter what interval you pick. Just pick the same one and measure the results. And that was a perfect opportunity to do so. So as you try to take on a variation problem and bring consistency to it, if you've made the wrong choice, your data is going to show up and you will be able to reflect that and adjust. And one of the things we're finding is as we deal with slides like this, we can get into arguments pretty quickly about what's the right approach. I think we need to think like James and just say it doesn't matter. Just do it consistently and keep measuring, because eventually you will get to the right number as your data comes through. One thing about quality improvement measures on the fly like this is they can be dead wrong. Okay? This is hospice days, a standard measure that everybody looks at, and the groups told us these are completely erroneous. I'm sorry. That this group in particular said, I can prove to you you're off by a factor of 10, and they did. So we've dropped this because our United Claims database doesn't pick up hospice very well. And as a result, we don't have accuracy. But that was what we learned by having a discussion about a quality improvement measure. And finally, let's talk just a little bit about dollars. Here's a medical group that came to me about a month and a half ago and said, we are doing very, very well. Look at our survival statistics. We're a point better here, we're a couple points here. And in lung cancer, they actually had they almost doubled the 5-year survival, which was pretty significant. And the first thing they said was, let's do a pay-for-performance program because we're doing better, we can prove it to you, we think that's more value. So we said, makes sense. And the first thing that we did then was go up and calculate what it costs to get cared for there. If you look at all the peer groups that they have in the state, they're about 33% higher already. And if you look at the national averages, they're about 33% higher. We said back to them, you've been on a pay and performance program for a long time. My only point about these slides is as we improve quality, it's got to be proportional or relational to the increase in costs. And in fact, I think as we look at most quality programs, you'll find they reduce cost. Okay? And the final comment that I'm going to make about all of this as hodgepodge of quality improvement measurement is that the statistician still has to be involved in the process. This is a trial that we did. We used a large medical oncology group. They had put in a pathways program and they wanted to measure it, again, along a pay-for-performance measure. And as you can see in the control period, or in the pre-period before the pathways went into effect, there was a large difference in cost between our national average and this particular group. I'm sorry, it's the other way around. This is the group. These are our controls, they're our national average out of the database. They were a lot more expensive. In the post-period, after they put the pathways in, both of them, everybody went up, but the gap narrowed substantially, and the statistical significance of that difference disappeared. Great, a win, except that it's unadjusted. Okay? We didn't take into account case mix here. What was breast, what was lung, what was colon? And once we did that, every statistical difference disappeared. So you can't let the statisticians out of the process, and a lot of the literature that I read right now, I don't think the statistics are quite as tight as they need to be, and we can get misled by some of the studies that are being done today on differences between differences. So that was a slide I was fishing for a while ago. Let me just end by saying this. It's entirely possible to do quality measurement for cancer. I don't think there's any question about that at this point. And I would emphasize that the more you can do it with someone, the easier it becomes. Collaboration can only be a win-win deal. Part of collaboration is pooling the data, and the other part, the most important part, is being transparent. so that there aren't any hidden black boxes. All the examples I gave you today, we've changed on the fly because as we had our dialogue, we recognized there were problems. And it wasn't a dialogue that said, oh boy, are you bad? It was a dialogue saying, oh, here's a gap. How do we fix it? How do we improve it? Finally, you can measure improvement, but here's the sticky part of that. You need very instantaneous data to help people improve. So when we looked at that group with the high hospitalization rate, they needed a list of all the patients, and they needed it then so they could go back, start reviewing charts and doing work. They want to know if they've gotten better, and that takes, unfortunately, another year or year and a half of data. So there is a need for instantaneous information to manage the problem, but when you're measuring the change, that takes time, both to accumulate patients and to get the data in, and that's a tough juxtaposition for folks. But it's well worth doing. And as I said at the start of the thing, I don't think accreditation makes much difference here. I don't think those measures are actually going to get patient care better. The kind of work that we're talking about measuring for quality improvement and having an open dialogue about it is what's going to get us to where we need to be much, much faster. What is very clear is that we're going to have to change. There is no way that the current environment that Peter described can continue. And I'll use the statistic. I managed to work it in. I do it every talk. In 3 years, it will take 50% of the average U.S. household income to pay for your out-of-pocket expenses and a family insurance premium. 50%. And in 15 years, that will be 100 if we use the current trends that we have today. That isn't going to happen. So what is very clear is the environment is going to change. How? I'm not completely sure. And if anybody knows that, I'd love to talk to them. So. Somber group. Okay. Thank you.